Over to you, doctor.
Yeah, 1 minute.
Audible? Hello?
Yeah, 1 minute. Yeah, just logged out.
Yeah,
Can you see my screen? Viewers, can you see my screen?
yes, sir, your screen is visible to me.
Okay.
Dr. Sushil Pawar, sir, can you see the screen properly?
Yeah.
I'll start,
Well,
Shashidhar.
yes, sir, he has already asked to start. It is ready. Recording
Good
is
afternoon,
started.
doctors. We welcome you to the experience sharing program on managing PPH, case studies from labor room. And today we have got Dr. Sushil Pawar with us, who will share his experience. This program is brought by Hetero Healthcare. And Hetero Healthcare, as you know, doctors, we have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and we have presence in 126 plus countries. We have 21,000 employees globally and we are the largest closely held pharmaceutical company. We are among the largest manufacturers of ARV, APIs and FDFs in the world. Hetero Healthcare, 360-degree solution provider, we strive to fulfill unmet healthcare needs, reach out to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have the distinction of bringing 4 biosimilar products within 5 years of initiation. We welcome you to this experience sharing program. Today we have got Dr. Sushil Pawar with us. Dr. Sushil Pawar is MD DGO FMAS, Fetal Medicine Certified Sonologist, Fetal Medicine Foundation. Sir has worked in Civil Hospital Nasik for 3 years and practicing laparoscopic surgeon from 2022. Currently carrying out tubectomy camp at various government hospitals in Nasik district. Currently working as consultant obstetrician and gynecologist at Pawar General Hospital, Sinnar, Nasik. Currently focused on managing cases in high-risk obstetrics, eclampsia, GDM, anemia, elderly pregnancy, and twin gestation. Main focus of area is rural. With this brief introduction, Dr. Pawar, I welcome you and hand over the session to you. Over to you, sir.
Okay. Thank you, sir, for this introduction. First of all, I would like to thank Hetero Healthcare for arranging this Zoom meeting, and it is a good advantage for us to bring us PPH under control. So first, I will start with the overview for PPH, that is postpartum hemorrhage. Uh, can we move to the next slide? Okay. Yeah, basically everyone knows what is PPH, but knowing is not enough. We must also be practically aware of what to do in PPH cases, because PPH is not just a theoretical thing. We need to manage the patient within few seconds. So, what is PPH? PPH is the any blood loss occurring after vaginal delivery or cesarean section, which is more than the normal limit. That is PPH, and PPH is can occur at any time to any woman. There is no specific. We don't have a specific data that which ethnic group or which type of woman may undergo PPH. So PPH, for that every physician or every obstetrician must be prepared for PPH for every delivery, not any delivery, for every delivery or any cesarean section. So, and it is one of the leading cause worldwide and especially in India for maternal mortality. Near about, I don't know the recent data, but it is about 35% of the maternal mortality is due to PPH. Okay, can we move to the next? Okay. Yeah, here we can see the regarding the postpartum hemorrhage, that is PPH. We can in this slide we have the rough statistics yeah, about the in developing countries and in developed countries. Even in developed countries also, PPH is a big issue. So overall, this is not a problem for developing nations only. It is a problem for worldwide. Globally, every obstetrician faces this issue. As I told you earlier, that PPH is it doesn't come with some specific background. Any woman can land up in PPH during her delivery. Okay, next. Yeah, these are the etiology for PPH. The basic and the main one is the tone, that is uterine atony. Yeah, okay. What is atony? It is inability of the uterus to contract after the birth of the child, and it causes the continuous bleeding. The second is the coagulopathies. Any coagulopathy causing in failure in clotting. It can cause this one. The basic is DIC. It can cause in PPH. The third is the trauma, specifically after the instrumental deliveries or after cesarean section. There might be uterine inversions, or in deliveries also. There can be injury to the birth canal, like the cervical tear, and many others. So we should be trained to manage such complications also. And the third is the tissue. Yeah, the tissue here specifically resembles the placenta and the placental clots, or the written products of conceptions. Okay, so I have later I'll tell you one of my experience regarding this RPOC, or the written product of conception. So this is also the main cause of PPH. So overall, we'll cover up this when we talk about PPH and how to tackle PPH. Next. Yeah, here the clinical findings. Okay, so any obstetrician, he's taught that whenever we will find these clinical findings in the setting, we should get to the diagnosis of PPH. So the first is abdominal tenderness. So whenever there is intra-abdominal bleeding, there might be other traumatic causes. There can be abdominal tenderness. The second is circulatory collapse. So at the time of delivery, the obstetrician is basically, he is at the towards the leg end of the patient. So there must be an other caretaker who should be at the head end, who should monitor the vitals after delivery. So the circulatory collapse means pulse, BP, and the other vitals. Okay. The third is the increasing abdominal girth. This specifically is regarding when the patient is shifted to the ward, or on the recovery room after the cesarean section or the vaginal delivery. There might be the increasing abdominal girth, which shows that there might be an intra-abdominal bleeding. Okay, and the fourth is the loss of uterine contractions. So a lot of you, this is just immediately after childbirth. We need to reach to the fundus to see that there are the other after the postpartum there are uterine contractions also. The second last is the maternal tachycardia. Maternal tachycardia is basically due to the bleeding which is occurring either through vaginally or intra-abdominal. And this vaginal bleeding is the last clinical finding we can see in PPH. I would like to add one more in this case, that for this one, the patient itself stops talking to us. We should continuously have a conversation after the delivery of the baby with the mother, how is she feeling and all those things. Besides this is the last clinical finding we can appreciate, because if she's going in circulatory collapse, we can easily identify through the verbal discussion with the patient. Okay, the next. Okay, this is the same. This is the same sequel of the what I have just spoken. We have to get to the diagnosis of PPH, and this is the main time that this is the golden period for the patient after making the diagnosis. So the rapid assessment of the patient status is required. The presence of clinical vitals we need to assess, and immediately we should call for help immediately when we have diagnosed with PPH. Okay, so we should know that the exact cause, whether it is traumatic, whether it is written due to written product of conception, whether it is atony, and simultaneously we have made the diagnosis of PPH and its cause. We should call for help. So like call for help means we should go, reach out other doctor for help. We should reach out to nurses. We should reach out to the paramedical staff for arranging the this thing lab and blood products if required. And if even we should go for this coagulopathies lab parameters also. Next. Yeah. So now we have made the diagnosis. We have made for help. Everything is we are under our observation. Now we need to manage the patient. Okay. So first of all, if it is due to the atony, we should go for uterotonics. This before going to the uterotonics, we should assess the IV lines. So now every woman undergoing vaginal delivery or cesarean section, she's already having secured IV lines. So the first thing, whenever we find out poor uterine tone, we should go for the IV lines. The next is we should go for the blood investigation. We should know whether she is having any coagulopathic disorders or whether she is having good blood count, that is the hemoglobin, and other things also, like the USG report also. If there is in the previous USG report of the obstetric scans, if is there any mention of any bicornate uterus, arcuate uterus, these things should come to our mind immediately. And as I told, the uterotonics. So there are a lot of uterotonics. We'll talk after regarding that also. And after that, we are having the other this thing also, mechanical. And also that is mechanical yeah, management, like inflating the Buckley balloon and any balloon tamponade. For these are for the uterotonics. Now we'll talk about the tears yeah, during in the birth tract, the vagina or the cervical tear. So we should go for those. We should find out those area of bleeding. So if there, this can be categorized like extragenital tears or intravaginal or cervical or below above cervical. Above cervicals are difficult to diagnose sometimes in vaginal deliveries, but we should know, like I have taught, I discussed this in this clinical findings, that abdominal tenderness is the sign of above cervical tear. So the next thing we should go for immediately is to the site of bleeding, and to start suturing, take hemostatic sutures at the site where it is bleeding. If we are having an cesarean section, if the patient is undergoing cesarean section, we must identify that time. It is very clear for us to get the overall view, that is the posterior side of the uterus, the lateral side, like the broad ligament hematomas and all those things can be clearly visualized in such cases. And the third one, that we have talked earlier, the coagulopathies. Actually, every obstetrician, when the patient is under his or her antenatal care, that time he had already gone out. He has already worked out with the coagulopathies, so already has in mind regarding the coagulopathies. And the last thing is the return product or the return tissues. Whenever we deliver the baby, and after delivering the baby, we go for the delivery of the placenta. That time we should examine the placenta also, because it gives the idea whether the placenta is completely expelled or the membranes or anything is inside the uterus. Okay. And all these things should be parallelly done with the making diagnosis of the PPH. Okay, next. Okay, here is a bit this thing. We are moving to the uterotonics. Now, the uterotonics, which the recent it allows us all the sleep after delivery of the baby. Okay, so this is the comparison between oxytocin and carbetocin. The conventional oxytocin, we everyone know that it is having a short duration of half life, and the shelf life is also very less. Now, previously we used to store in refrigerators, and yeah, obviously there are some protocols why we should keep it. Same is with carbetocin, but carbetocin is now freely available with heat stable formulation also. So it gives an extra advantage. for the obstetrician, and it increases the shelf life also. So now we are having both the drugs, carbetocin and the heat stable formulation of carbetocin also. Now we'll talk in the next slide regarding the same. Okay. Yeah, here we come. It is the regarding the use of uterotonics have I already discussed. It depends on every obstetrician where to use the uterotonics. Some of them go whenever there is crowning of the head, when the other few obstetricians they think that it is better to give the uterotonics or the oxytocin at the time of the delivery of the anterior shoulder. Some obstetrician they believe in giving in the second stage of the labor. Some obstetrician they think that better to give in the third stage of labor, that is after delivery of the placenta. Every protocols differs, but every intention or the aim of you giving uterotonics is just same, to prevent, and that is prophylactic for PPH. Okay, and here in this slide you can see the some molecules. The basic oxytocin, everyone know about it. The second is carbetocin, we'll talk about it later, and the third is ergometrin, which is very sparsely used nowadays, only in a few cases where we use ergometrin. Symptometrin is still in the Western countries. Some countries prefer symptometrin also. Okay, what is symptometrin? It is nothing but mixing. It is a mixture of argometrin and oxytocin. And the third is misoprostol. Actually, misoprostol we don't have any parenteral formulation till yet. So misoprostol is preferred by per rectal or some prefer sublingual use also. But for the first two are better in management of PPH. Next. In between, if anyone wants to just stop me, just let me know. Okay. Okay, now this is the drug. This is a comparing the molecular structure of carbetocin and oxytocin. Here we can see the actually there is not much difference in oxytocin and this thing. Only a ring is a bit different. They are the twin brothers, we can call them. A slight difference in oxytocin and carbetocin in structural formulation. But yes, in the way of working in pharmacokinetics, yeah, they are a bit different because there is prolonged half-life for carbetocin, and the degradation is very slow for carbetocin in compared to oxytocin. Okay, okay, next slide. Okay, now here we'll see the clinical evidences. Now, yeah, here the same. Here, what I've talked earlier, the use of and the difference between oxytocin and heat-stable carbetocin. So, see, carbetocin is the reserve drug, or it is to be used after the delivery, okay? And oxytocin is a drug which has a multiple role. It is used for the induction of labor, augmentation of the labor, prevention of the PPH, and the treatment of PPH. But whereas carbetocin, it is the drug for prophylactic use of PPH. But some of the obstetrician nowadays, they are preferring it in management of PPH also. Okay, the drug design or the birth of the drug was mainly for the prophylactic of PPH management. But I have my some example that in PPH cases, instead of prophylactic use, I have used this drug in management of PPH. That time it also had a good result. Okay, so here we can see the for half life, as I've earlier told, it is very short for oxytocin. It is 1 to 6 minutes, and in for this carbetocin, it's 40 minutes. So we can have a good this thing reliability on this drug after giving after shifting the patient to the wards also. Okay, next. Yeah, here we can see the famous WHO champion trial. What it is not the champion trial, actually it is the short form of this thing, carbetocin hemorrhage prevention. So they have given this name, champion trial. Okay, this was a large worldwide trial conducted by WHO, and its only objective was to see the effectiveness of heat stable carbetocin versus oxytocin in prevention of PPH. And this main this what we say uh, the aura of this trial was, it was only conducted for vaginal deliveries. It was not conducted for cesarean section. Okay, so in this, it was clearly that the blood loss for prophylactic use after prophylactic use of carbetocin, there was significant risk reduction in this thing after the use of carbetocin. Okay, next. Okay, yeah, this is the same. The efficacy between the comparison of efficacy between oxytocin and carbetocin. Yeah, we can. There's the efficacy. If instead of efficacy, we should go for the outcomes. Okay, the efficacy there is not much difference, but when we compare the clinical outcomes, that time there is carbetocin is slightly superior. This is the same trial, and these are the data which under champion trial, and it clearly there was, we can't say the winner, but we can say that clearly the carbetocin was uh, a bit ahead and not behind oxytocin. Okay, next. Yeah, this is a Cochrane review. It says the same, that carbetocin for preventing for postpartum hemorrhage. Say there's even if Cochrane reviews is they have elaborated with cesarean section data also, and clearly actually I have earlier told that symptometrin, they have compared it symptometrin, and symptometrin is widely used in Western countries. So in they have compared this thing, and they have found that better it's carbetocin in compared to the side effects with symptometrin. So the side effects are very less with carbetocin rather than symptometrin. And they, of course, they have found that the therapeutic uh, uh, effectiveness of carbetocin is better than symptometrin also. Next. Yeah, so these are the guidelines worldwide regarding the use of carbetocin or uterotonics in PPH prophylaxis. Yeah, WHO, we have in the whenever we talk about the WHO, there is the WHO has the worldwide data. So WHO asks us to use, or the advises us to use oxytocin, carbetocin, methergine, and this one, sorry, ergometrin and misoprostol also. But some Western countries, the developed countries, they are now shifting. They have shifted their protocols to carbetocin. Yeah, the basic dose is 100 microgram IV bolus, and the same is for carried out in many of the other countries like Germany, France, and all those things. But yeah, in India also, recently many obstetricians have started using IV bolus of 100 microgram immediately after the baby delivery. Okay, next. Yeah, here there are some experiences I would like to share regarding
Yes, sir.
carbetocin.
Thank you very much, sir. Coming to your experiences, 1 minute.
Okay.
This is a case study which you have shared.
Yeah, yes. This one was one of my very few case where I've used personally, and luckily I had the photos also. The patient she had one fibroid also. She was the second gravida, and she was a case of previous LSCS with breech presentation. It was an emergency cesarean section, and after the baby delivery, the placental separation was very difficult in this case. So naturally, whatever the protocols were carried out was the giving pitocin drip immediately after the baby deliveries. The lower segment was a bit flabby, and we were not able to control the bleeding. So we went with giving injectable ergometry, but still there were we yeah, the satisfaction or the bleeding was not controlled. So we should we've decided to go with carbetocin. Actually, here it is the case of management of PPH, but still I had a very good outcome with giving carbetocin IV bolus, because within the IV dose. Bolus dose in the 3 to 5 minutes, we had the placental separation. That was not the entire placenta, but there were bits of placenta, and we were able to separate it immediately after 4 to 5 months. And beside that, we got a good tone after uh, giving this thing, uh,
Sir, any
carbetocin.
specific
So
reason why methergine was used here?
yeah, actually it was a lower segment
Okay.
placental adhesion.
Mhm.
Okay, so in this case, we first preferred to give
Before it.
argometrin methergine, but later methergine also didn't give us a good result. So we shifted to carbetocin. Yeah, this is the second case. This was a multi-para. She was G6 para 5, and she had two living children only. And she was a very good case for me because she had this was very precious pregnancy for that particular female. And the baby weight, the patient weight, I forgot to mention here, the patient weight was near about for 36 or 37 at the time of her delivery. Okay, so she went on smoothly till the active labor. There was no problem with augmentation on all those things. And immediately after the baby delivery, as a routine practice in every Indian scenario, there is a practice of giving injection oxytocin in IV drip. So we started with that. The placenta delivery was good. There was nothing this thing. And after that, we gave her methergin injection. Yeah, this was the first time I trusted. I started shifting onto carbetocin because this in this case. I gave methergin injection, and still there was no the bleeding was not we were not able to control the bleeding, and the uterine atony was far means till I went for mesoprost per rectal, she had already lost her 600 to 700 ml of blood loss. So we started our active management for third stage of labor, but still the bleeding was the same at the same rate. So the first time, this is the first case where I used the carbetocin injection, and we gave the carbetocin bolus shot, and we started with the uterine fundal massage. That is the active management of the third stage labor. And yeah, believe me, this was the this was the case where I started trusting with carbetocin injection. And after that, so successfully we managed this case. But from that day onwards, we omitted the second drug, which I mentioned here, argometrin derivative. We stopped using that drug, and we have shifted now to carbetocin after this case only.
In both these cases, sir, you have used IV form.
Yeah, IV. And the main thing is here for both the cases, I've used for management, not the prophylactic.
Yeah, correct. That's it.
Yeah, this is the third case. Yeah, here this is very classical case. This is just 3 to 4 months back. We went for cesarean section for this case. Actually, this case she had a vaginal delivery some 12 years back. But this time, the patient, when she took 9 months treatment, she was under me only for her antenatal care. Her request was for elective cesarean delivery because she had a PPH experience in her last childbirth. So she clearly had the firm decision for elective cesarean section. And the main thing beside this, she was a beta thalassemia trait, minor trait. So now we schedule the case for elective cesarean section. We for this time, because of her past experience, we had all the blood products and blood reserved for her. And whenever and when we have I have personally instructed the anesthetic at this time when we started the cesarean section, that immediately when the baby is out, you just give the carbetocin bolus dose. So yeah, this time we had this fantastic the outcome with carbetocin. Yeah, the patient, we need a minimum post-operative monitoring for PV bleeding. Okay, when intraoperatively we can clearly, whenever in cesarean section, the uterine tone, we can see the magic within our eyes, that immediately the patient, after the patient delivery, the placenta expelled, baby delivery with the placenta expelled very smoothly, and no need to give any extra drug, no need to give this oxytocin 20 units protocol, no need to follow. Just we gave carbetocin single shot bolus dose. Yes, and we didn't need any other uterotonics, and we didn't need any blood transfusion. And this time, I told the patient that 12 years back might be there, this drug was not there, so you landed in PPH. And this time I told her that you were saved by this drug only due to from PPH. Okay. Any questions
Yes.
regarding
Thanks, sir.
this
Thanks
case?
for sharing your cases. It's very interesting that in spite of using methergine and oxytocin, the patients did go to PPH and which are finally controlled with carbetocin.
Yeah.
Yeah.
And one thing I would like to share a few more words with you. That see now PPH is one of the leading cause. So every pharma company, or whether it's a government body, or whether it's the doctor's end, everyone should focus on controlling rather than controlling management of PPH. We should go for the prophylactic
Prevention.
management
Correct,
of
correct,
PPH.
correct, correct, correct. Very correct, sir. In fact, some of these questions highlight that. What is the patient profile generally, sir? One, you have mentioned that past history of PPH and past
Yes.
cesarean section. Anything else
Uh,
that doctors can expect to PPH?
Yeah, one thing I would like to share with this that there is no such patient profile.
Oh,
Every patient, any patient, or every patient can land in PPH. So
yeah, yeah.
whenever the patient comes, we take her on the labor table and we start augmenting the patient. One thing should everyone should keep in mind that this patient can go to PPH. So we should be prepared for every patient. Not we should anticipate that every patient can go in PPH.
Expect the unexpected, as we say.
Yeah, we should be prepared.
In which patients would you prefer to use carbetocin over oxytocin for prevention of PPH? Any such cases?
No, but yeah, actually, see, whenever we go for twin deliveries
Ah,
or the past history, that time we are having multiple pregnancies. That time we should go for this thing. And obviously, like in GDM recently, just 4 to 5 days back, there was a case of gestational diabetes mellitus. There, the baby weight was about 3.8 kilograms. That time I preferred using carbetocin over
correct.
oxytocin, because I had in my mind that she might land up because of the weight of the baby. She might land in PPH.
So, does gestational diabetes reduce the tone of the uterus?
No, it doesn't reduce the tone, but gestational diabetes do cause the stretching of the uterus.
Hmm.
Because for my case recently, it had that baby weight was more than
Big
3.5
size baby.
kgs.
Yeah, big size baby.
Yeah, big size baby. And also in this thing also, polyhydramnios also. In
Volume.
cases of polyhydramnios, where there is a stretching of the uterus beyond its limit, that time we should be this thing. We should anticipate PPH.
Can we use carbetocin? In fact, you have used in case of retained placenta, manual
Yeah,
after
yeah,
only manual removal of placenta.
yeah,
Yes.
yeah. This was one of my case.
And in RH negative mothers, sir, what is your opinion?
Yeah, we can use it. No, there is no such data that we shouldn't use We shouldn't
Although
use
rare, it's an
carbetocin.
important thing. We can expect some RH negative patients, and then there could be an issue.
Yeah, no, actually there is no such data still here.
Yeah. Can a doctor use carbetocin for prevention of PPH if oxytocin is used for induction? In fact, everyone uses oxytocin for induction.
Yeah, yeah, no problem. Yeah, carbetocin. Whenever we for yeah, see, whenever you are giving carbetocin for the this prevention of PPH, that time we shouldn't use oxytocin simultaneously. But yeah, before that, if it is used, no problem now, because already the half life is less. So
Less.
when we have disconnected the oxytocin, then the effect of oxytocin is already
Have gone.
waned off. So we should go for carbetocin after discontinuation of oxytocin.
In which cases you would prefer IV? In fact, you have preferred IV in all cases. Would there be any case where you would prefer IV? I mean, I'm
No, I would prefer IV route only because
IV.
of
Faster
the
onset of action.
bioavailability. Yeah,
Yes. And in PPH, finally, the speed of action matters.
yeah. So
When few seconds will
already
matter.
it is a 20 it is like a 2020 game. You have
Oh,
very
yeah,
short
yeah.
period. You have to do everything in that few seconds only. I would not say minutes. It is a few seconds.
Absolute, absolute, absolute. I mean, this is the same question. The patient is not responding adequately to carbetocin. What additional? I would say everything. Whatever we have.
See, yeah, but everything it shouldn't be used at a time. We
Ah.
should wait for carbetocin
What
also.
will your
Let
what
it.
would be your sequence?
Yeah, see, after carbetocin, simultaneous means we should stop oxytocin after
Yeah.
giving carbetocin. Then, even after carbetocin, if you are not getting enough tone, there are other drugs also, like prostaglandin and agonist and those things. But we should get the patient profile also. Like we have carboprost also.
Asthma,
So
etc. To see.
yeah. Yeah, and we should go. We can also go. In one of my case, I have already used misoprostol, but it was before giving carbetocin. But yeah, these are the reserve drugs. We can use misoprostol also, and we can have and rather than going for many for pharmacological products, we can also go for mechanical control,
Yeah,
like using balloon
massage.
tamponade, uterine
Correct.
massage. Yeah, that those things are very useful in such
Absolutely.
cases.
You are very rightly said. Rather than pharmacology, sometimes the physical measures can help. Over other uterine tonics, the advantage of carbetocin will be
Yeah, it's sudden action. Yeah, uh,
that
we can
fast
see in
onset.
yeah the in compare when we compare oxytocin and carbetocin,
Oh,
the advantage of carbetocin is the half life is more that we everyone but the uterine contraction it is sudden. Okay, and the second advantage over oxytocin is that it is this drug is where we can get in heat stable form also.
oh. Should carbetocin be kept as a reserve drug or it should be used as first line?
This question depends on whether we are asking for prophylactic management or a treatment modality. In prophylactic, this should be the first line of drug, and in many of the other case, when we are treating PPH, that time it should be a reserve drug.
Reserve drug. Sir, what is the role of anesthetists vis-a-vis?
Okay. See, anesthetist role is very much important in such cases. Like I have earlier shared with you one of my experience.
Yeah,
That time I personally had discussion with anesthetist regarding the use of carbetocin. So at that time I told him earlier only there's no just discontinue the oxytocin drip when the baby is out. Just go for carbetocin. Why? Because see, the role see he's the one who is going to have the medical management in cases of PPH while handling is going in
correct, correct, correct.
cesarean section. And the second thing, the most important is that after giving this drug, he is the one who is monitoring the vitals, so he
Yeah,
can go for that after giving this drug, and he has already given the other drugs also
correct.
prior to giving this drug. So his role is
The
very
best judge,
important than
yes, correct.
gynecologist drug role.
So one question has come from the audience from Dr. Sujata. Is there any deadly complication of carbetocin? If carbetocin fails, of course, you have answered this part. If carbetocin fails, what next? Whether it has to be repeated. Do you repeat carbetocin anytime, sir?
No, 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 no. This is
And
what I personally think is that this drug should be used only
single
once.
drug.
Yeah, and if it fails, then go for other drugs. We have lots of drugs or lots of treatment modalities.
And is there any deadly complication of carbetocin?
No, actually, not yet. Actually, see, this drug is very recent drug.
Oh,
So till it is an trial in the market, okay. So we don't have any adverse drug reaction till yet, till carbetocin, and no allergic things. Allergic reactions were also not noted
correct,
with
correct,
this.
correct, correct. One more question, sir. Which route is preferable? IV and IM. You have answered this, of course, but you prefer IV route.
IV. See, this is a
Or faster
this is
onset
an
of
emergency
correct.
case. Super emergency, I would like
Absolutely.
to say.
Would you like to add prostodine if carbetocin fails?
Yeah, we have it is a reserve drug. We can go for prostadine also.
Also, if carbetocin fails. It is said, it's said that if carbetocin fails, other drug doesn't help. Is it true?
No, it is not like this. Because see, for first thing, what is the cause of PPH? We should understand it
Absolutely.
first.
Yeah.
Everything depends upon the cause of PPH. So
Correct.
whatever, if it is attorney, then there is nothing like if he fails, then it in
Correct.
obstetrics there is nothing like this is number one drug, this is the second
Correct.
choice, the
Absolutely.
third, whichever works, it is the drug of choice.
Absolutely. And sir, coming to the questions, the last question to conclude, what is your overall experience? I mean, take home message.
See, if any obstetrician wants to sleep, have a good sleep after delivering a mother, he should go for Carbetocin. Because there are lots of cases we experience, that when the mother is shifted to the ward, that time that's the secondary PPH, it occurs at that time. So Carbetocin, it immediately postpartum and the late postpartum, both PPH are controlled by Carbetocin. So overall, I would like to say, use it wisely, and you use it in every cases where in case of prophylactic PPH.
Thank you
And
so
for
much, sir.
yeah,
Thanks for sharing your experience. I mean, thank you very much.
okay, thank you, sir.
And I thank the marketing team of Wipro, the IT team for their support, and of course the sales team for super coordination. Thanks, Dr. Sushil Pawar. It was wonderful having this session with you. And thanks,
Thank you,
audience, for
everyone,
some
for
of the wonderful questions you asked. And thank you for the time that you took in the afternoon to attend this webinar. Thank you.
thank you, everyone.
So
Thank you,
you can
everyone.
sign off, sir. You can log out, sir.
Thank you, sir. Thank you so very much. Once again, it was really insightful session, and your cases, added to